I want to welcome you to our Candor workshop. My name is Tom Evans. I'm the president and CEO of the Iowa Healthcare Collaborative, and it's really a pleasure to see, excuse me, all of the people that I recognize from our hospital environment here trying to get your brain stretched. I have to do my obligatory announcements first and make some introductions, and then I want to make some introductory comments about kind of why we're here. Housekeeping notes, be sure to turn your cell phones off or to silent. You know, every time they put that in here, I know they did it for me. So everybody turn your phones on to silent. Restrooms are located just behind the registration table when you come in off the elevators. Continuing education, there are 7.25 nursing contact hours available for today's program. You should have received a CEU form when you arrived today. If you did not, please get that form now. Forms need to be completed and turned in at the end of the day, and you have to attend the full day to get your credit. There will be an evaluation. You'll receive an email link to respond and tell us what you thought about the program, and we just really, really want you to tell us what you thought. This is a new thing for us, this particular venue, so we're very excited about it today, and we want your input. So please take a moment to fill that out and send it to us, and afterwards you'll get a certificate of attendance that you can use for all your self-reporting continuing education credits. Parking validation tickets will be available to cover the cost of parking in the ramp. And then I want to thank our sponsors today as well for this, COPIC and Iowa Medical Society for their support of this important topic. We have a world-class team with you today, and I'm very excited to introduce our team. Bruce Lambert, PhD, received his doctorate in speech communication from the University of Illinois at Urbana-Champaign. He is a professor in the Department of Communication Studies and director of the Center for Communication and Health at Northwestern University. His research focuses on health communications, patient safety, and medical liability reform. Bruce is a principal investigator on a 5-year grant funded by the Agency for Healthcare Research and Quality, AHRQ, to study techniques for preventing wrong drug and wrong patient errors. He's the president of BLL Consulting and Farm IR, which are firms that solve problems involving health, communication, and technology. And he blogs out communication on How Communication Works, all one word, .com. Bruce, wave your arms there. Thank you, Bruce. Give him a hand. Okay. Our next faculty member, if you will, is Christina Melizo Chavez, who is a patient safety and advocate who lives in Hobart, Indiana. Chrissy graduated from Purdue University in 2000 and currently works as a teacher in the Hobart school system. She's fluent in Spanish. Her advocacy works extend to coaching on how to communicate with people who do not speak English or from whom English is a second language. She became involved in Candor work after the death of her sister Michelle in 2008, caused by an anesthesia event and other failures during the course of her career while undergoing a surgical procedure. Chrissy and her parents, Bob and Barb Melizo, are involved nationally in healthcare transformation work, and they often speak about their decision to honor Michelle by working together with providers to make healthcare safer, more transparent, and trustworthy. She's motivated to ensure that comprehensive patient safety systems are in place for young people, including her children and Michelle's as well, for generations to come. I hadn't really known that Chrissy was coming, and then when I saw the list, I put two and two together, Melizo. And I actually have a picture in my office, Chrissy, that has a bunch of patient safety champions, and your mom and dad are both in that picture. So glad you're here. Please wave your arms, and everybody, let's give them a hand. Last but not least, the world-famous Tim McDonald, MD, JD, the president of the Center of Open and Honest Communication at the MedStar Institute for Quality and Safety, and a professor of law at Loyola University in Chicago. Dr. McDonald is a physician attorney, which a physician attorney is a special category. It's a type of physician who has insomnia. They have a hard time sleeping at night with themselves. A physician attorney whose research has focused on principled approach to patient harm with an emphasis on reporting of patient safety events, the use of simulation and human factors analysis, and providing open and honest communication following harm events. His federally funded research has focused on these domains and their impact on improving the quality of care while mitigating medical liability and other legal-related issues. Wave your arms, Tim. Please join me in welcoming Tim and the rest of the team. By the way, Tim, those were all statements of love. That was not, and respect. When Kate and Jen asked me to make some comments here early, yesterday, it was like, wow, this is the Candor thing. And I got to thinking, what am I going to say? Because I got Tim McDonald following me, and wow. And I got to thinking, well, the one thing I bring to this discussion is a little bit of perspective. And I think it's important for us to think a little bit about how far we've come. I know there's a lot of hospital people in the room. Do we have any physicians in the room? Okay, few. Okay, now, but the reason I want to bring this up, I want to talk about this, is that we've come so far over the last 30 years in a journey of how we interact with our patients. And I want to just tell you some of the milestones that I've experienced during that time. I graduated from medical school in '83, but my journey really began in 1977. And in 1977, see, my dad, I was in college, but my dad's an insurance agent, and there was a malpractice insurance crisis in Iowa. And my dad really worked with the Iowa Medical Society to develop a malpractice insurance product that would be available for the whole state, because no one could buy malpractice insurance, okay? So my dad became the sole source agent working with the Iowa Medical Society at that point to sell malpractice insurance to the physicians of the state. Now you're going, who cares? Well, malpractice insurance is what you do when you screw up, and you got to have coverage. So my first experience with this whole patient engagement and risk world was around how do we interact with our patients? And it really began an interest in my mind. How do we mitigate risk? Or better yet, how do we not get sued? And over the course of my career, then I was on the board of directors for MMIC, and for this product that the Medical Society eventually developed and then sold to somebody else. But long and the short of it is I was on the claims committee, and I learned a lot about how stupid we are as providers. It's how we communicate with our patients. You know, patients usually sue more because of our communication style and our stupidity. It's not that we're stupid like with regard to skill, but it's with regard to either arrogance or not listening, not engaging, not respecting the patient. And it really was something that moved me. Okay, that was one track that influenced my career. The other one was, in about 1998, there was this movement that developed within the medical community, the national medical community, around patient safety, and patient safety really began to take off. We always kind of linked quality and patient safety together, and some of you have heard me say this before. There's a difference between quality and patient safety. Quality, everybody understands that quality is the thing that we should all do, and how often should you do the thing that you should always do? 100% of the time, right? But patient safety, on the other hand, are unintended consequences. They're things that fell through the cracks. They're surprises. But how often should those things happen then? If you're not supposed to have it happen, it should be zero, right? So quality and patient safety, quality is putting systems in place to make sure that we do the right thing every time. Patient safety is making sure we put systems in place to make sure that we don't allow the wrong thing to happen. But it does. And how do we deal with that? How do we react? How do we engage? How do we protect the patient? In 1997-98, the American Medical Association started a foundation called the National Patient Safety Foundation. And the NPSF, it still exists today. It's now been merged into the Institute for Healthcare Improvement. But I was on the board of directors from about 99 through probably 2004. And I tell you this not because there are great lessons to learn, but because of just a reflection of how far we've come on communication. Because I believe that our communication style over the last 30 years in dealing with patients has moved from priest to partner. In the past, we have been those who have the knowledge, who have the power, and will have communication with the patients and tell them You should do this, you should do that. And if you don't do that, what happens? You're a bad person. Okay? We've been in this position of power and communication and almost a paternalistic position. And there's been a recognition over the last 20 to 30 years that that's a completely dysfunctional relationship. People sue the priest when bad things happen. But their partner, it's a different deal. And we need to be a partner with our patients. So we've been working to become partners. The reason I introduced NPSF is just an indication of how far we've come as a medical community with regard to patients. The board of the National Patient Safety Foundation in 1998 had about 50 members. It was a big representative board. Do you know how many patients were on that board? None. And I still remember the deep discussions we had in about 2000, 2001 about adding patients to the board of directors for NPSF. Do you know how many we added? One. And we thought we were so innovative. We were so good. We've done it now. We've let a patient into the tent of our holy priesthood. And now we will be changed. And changed was really just, the patients know what we do now. And it began the next discussion of, health literacy. If we could just tell them, if they just understood what we did, then we'd all be fine and we probably wouldn't get sued. It's because they don't speak our language is the problem, right? And we soon learned, just like an onion, that was one layer of the onion, to at least invite them into the tent. But we then learned that we needed a lot more than that. And then we decided we needed more patients on the board for the NPSF. And do you know how many we added? Two more. No, we were really innovative. We added two more. So the point, and I eventually stepped off the NPSF board about 2008 for time constraints. But the point I'm making is it's been a slow journey for us to get from there to where we are now. And I want to leave you that in Iowa, I was on the executive committee for the Medical Society, and from about 2000 through about 2004, eventually I was the president of the Medical Society. And I still remember introducing these topics to the board at the Medical Society, and the Medical Society would talk like, nah, that's never going to happen. No, we just couldn't get around that, and it began a discussion. And one of the things I'm most proud of for the year that I was president of the Medical Society, and Ed, you were there, but we introduced legislation that got approved at the State House that basically we called it the I'm Sorry legislation. And this was about us. We thought we were innovative because we got I'm sorry innovative, which basically said if an unintended consequence happens, the physician can actually say, I'm sorry that this happened. They can express remorse and not have it be an admission of guilt and be something that they would be sued for. So it was just the next little step. And now we have, and I'm not going to go into the Candor legislation because you're going to have more detail on that. I want to create a little bit of tension to show you that A, this has been a journey that we've been on for a period of time, and we're going to continue to advance. B, that this whole discussion about patient engagement, meaningful patient engagement, is an onion that we continue to peel back the layers. I remember having a discussion with Marty Hatley because he was also on MPSF's board. And we talked about generations of illumination. We'll add one person. We'll add two more people. We'll have I'm sorry legislation. And now we're at the next layer with Candor. And I believe there's going to be even more as we work together and learn together. Having Chrissy here to kind of help us tell stories and think and interact. This is all stuff as we move from priests to partners with our patients. So I want to commend you for coming today and thank you for coming today and challenge you to think, to open your hearts, and to think about how do we deliver services in a meaningful manner that actually loves people as well as just treats people. So with that, I want to turn it over to Tim McDonald. He's going to take us into the day. Let's welcome Tim.
Thanks, Tom. That was great. As Tom mentioned, I am a physician attorney. The practice of medicine I was engaged in was pediatrics and anesthesiology. And, there is a long history of patient safety and anesthesiology. In fact, the first sort of patient safety foundation was the Anesthesia Patient Safety Foundation, which was founded in 1984, 85 or so. Yeah, I know. So that's why I figured I would jump out there and share that part. So anyway, thanks for being here. As I mentioned earlier, there are just a few that are left up here. I put the communication assessments up here in alphabetical order. I have a bunch more that I'll be grading when Bruce and company are up here chatting. But I'd like to first start a little bit with objectives, but I'd like to hear from you and actually start over here. What are you hoping, just one of you speak up at each table, what are you hoping to get out of today? What are in your mind, what are some of your primary objectives? What would you share with the group in terms of your objectives today?
I would actually really like to learn more about Candor. We recently, within our network, and so we have a network group here today representing our network, but we recently had a very significant medication error that caused immediate harm to a patient. And in working with actually the CRNA's attorney, he told us to stop. There's this law, this Candor law, and we thought, what? Mm-hmm. And so we went online and we looked it up, and we found out that, goodness, there is a Candor law, so we should learn about that. And so I think as a partnership within our network, we're interested in certainly learning more about it, and then sharing our key learnings with the rest of our network.
Great, awesome. In fact, our first enactment today is going to be a big medication error that we'll be able to work on. You'll be able to huddle up and talk about, how might we go ahead and approach this. How about here? Anybody here want to share what your primary, how did you know that?
Because you were dead on just coming this way.
Well, this is all about transparency.
It is.
What do you hope to get out of it?
We came today, and we're just hoping to learn more how to connect with patients and open and honest communication, and go to not that we're not a culture of safety, but that we have to involve patients, family members, and everybody as part of their care.
That's great. Thank you. How about this table here? Somebody willing to share what you hope to get out of today?
Sure.
At the end, we're going to come back and say, hey, did we meet your expectations, in addition to the formal objectives we're supposed to have?
I'm here with my team, so there's 4 of us from our hospital, and it's all of the people from process improvement as well as safety. And so I appreciated Tom's comments about the differences, the distinctions between quality and safety. But we all work so close together, it would be nice for us to have a uniform platform about how we approach things and the words that we use. And communication is just so very important in the small things, and develop our skills in that way to help when the larger stuff happens. So.
That's great. Yeah, so stay tuned for Bruce. He is the smartest person I know related to communication. I mean, he's been doing it forever. He'll share a lot of that sort of stuff. And particularly when he shares the communication skills assessment, where it came from and how useful it can be for people. So great. Stay tuned. How about here? Anybody?
I think for me, I need to gain a greater understanding of Candor. And while we have a culture of safety within our facility, I think it's easy to say we have a culture of safety, but how do we live that every day? So how do we escalate that to the next level? And every single action we take at the front lines is aimed towards that safety.
That's great. Yeah, we will as you can kind of see, after we do some of the enactments of communicating to patients and families, we will get into a big just culture conversation. We have a really good video around that. And then, of course, that leads into care for the caregiver, which is how do we create a safe environment and help people through this. I love the fact, Tom, you use the word love, because a lot of what we talk about Candor and the real approach to it is the goal is when these things happen is to learn how do we hug and love patients and families, their loved ones, and the caregivers throughout this event until we come to some sort of understanding of what happened and some honest, resolution related to that. So thank you. How about this table? Okay, Darla. Awesome.
Thank you. Like many others, I want to gain a better understanding of the Candor law and to improve our communication with our patients and families.
How about this table?
I'm looking for, we've got the basics of Candor, but more caring for our caregivers. And then also, how do we bring this back and teach our physicians these same kind of things? So looking at training, and so internally, how can we work with our physicians to get them trained up on the logistics and what we're looking to do?
That's great. You're going to see a lot of videos here, and that's one of the things that I've talked to Kate a little bit about, is how do we sort of make those available to you. As you'll see, they are great opportunities to kind of figure out how we train and operationalize what's happening.
Just communication with the patients and the family after adverse reactions or what happens. Yep.
Great. Thank you. How about anybody here? Brian?
I would say what everyone else said. We're the last group down here, so I think everyone else kind of spoke for us, just trying to learn more about Candor, how we can help our providers, how we can help our staff, how we can have a culture of safety. All those things have been mentioned. I think it would be great.
Great. Awesome. So again, we'll revisit at the end. So at any rate, these are kind of the official objectives. We kind of break this out into two domains. The first is when things happen, how do we have that communication, with patients and families and loved ones in a variety of situations we'll be able to talk about. We will then get into the conversation a bit about just culture, but really focus this afternoon as well on care for the caregiver. This is going to be super interactive. We have some amazing actors that are going to be coming into play various roles. The neat thing you'll see is in the morning, they will play the role of patient and family member. In the afternoon, we're going to take those same cases and they'll play the role of a nurse who is involved in a medication error and a physician who is involved in a missed test result. So they really understand this work, and we're really excited about them coming. But Bruce, I'd like to have you and Chrissy come up. We do like to begin these workshops, as Tom mentioned, grounding us, anchoring us on the patient story and the real reason why we do this. So I'm going to hand this off to Bruce. And
I'm mic'd up. We're both mic'd up.
oh, you're both mic'd. Great.
Yep.
Thanks.
Morning, everybody. I'm Bruce Lambert, and this is my friend and colleague, Chrissy Milizzo. And we want to tell you a little bit about Chrissy's sister to just remind us why we're here. This isn't an academic exercise. We're talking about real people and their families that are sometimes devastated by medical mistakes. So we'll begin with this story, and then we'll move forward throughout the day about how we can try to model what happened with the good things that happened with Chrissy's family. So, Chrissy, could you just tell us about your sister?
Yeah, definitely. So Michelle was my one and only sister. She was 10 years older than me. She was a very fun person to be around. She was very social. She loved being around people. She was the local branch manager at one of the banks in the nearby cities. She had a daughter at the time that was 7 and a newborn that was 1. She was the most loving, understanding person I've ever met. She was definitely like a second mother to me. She was always there helping me whenever I needed her help for anything like that. She was giving back to the community. She would serve meals during Thanksgiving at different organizations and things like that. So she was always trying to give back to other people. And as you know, she passed away in 2008.
So Michelle was going in to have a stent placed in her liver. I won't go into all the medical details. At some point, maybe Tim can elaborate. But she was going in for an outpatient surgical procedure at the University of Illinois Hospital. And she was told she'd be in and out that day, and it was going to be done under moderate sedation. So could you tell us, Chrissy, what that day was like?
I remember waking up that morning. My parents had gone with her to the hospital along with her husband. I wasn't able to attend because I was limited on my days as a teacher that I could take off in the year. and she was going to be having a major liver reconstruction surgery in May, which was going to be much more severe, and she wanted me there for that. So I was on my way to work that morning, and I remember getting this feeling in my stomach like I should call her and maybe I should go. Maybe I'm just going to call off work and kind of go last minute. And I called her up and I spoke to her on the phone, and she said, "No, it's okay. I know you don't have a lot of days to take off. I need you there in May. It's okay. Everything will be all right. Mom will contact you when I'm out of the procedure and everything like that." And I said, "Okay, I love you. I'll talk to you soon."
Yeah.
So I did not end up going. And her procedure was supposed to be in the late morning, like 10 or 11 o'clock, and it kept getting pushed back and back later into the day. About 3 or 4 o'clock, they had came into her room and had told my sister and my parents that it's going to be a little bit longer wait if you want to have an anesthesiologist in the room. And my sister wanted to be completely put out because when she had the same procedure 2 weeks before, she kind of woke up and came to, and she said, "I don't want that to happen again." And they reminded her, "Well, that's fine, but you're going to have to wait an additional amount of time, and we're not sure how long that's going to be." And of course, after waiting all day and being anxious and nervous and just wanting to be done and get back home to her children, they reassured her it's okay, everything will be all right. So I left work that day, and she was supposed to be done about 5 o'clock. And my mom's very good about calling me, texting me, keeping me updated when things like this are done. And I went to pick up my son, and it was like 5:30, 5:45, and I hadn't heard from my mom. I was like, well, that's weird. She's super good about this. She knows how I'm like a nervous Nelly. Like, I always worry about things. So I called her phone. And my dad answered her cell phone, and my dad never answers my mom's cell phone because he has his own phone. And I said, "Well, Dad, let me talk to Mom." And he's like, "You can't." And I said, "What do you mean I can't talk to my mom?" He said, "She can't talk right now." And he started crying. And I said, "Why can't she talk?" And my dad said, "Well, she's talking right now to the doctor. Something went wrong during your sister's procedure. She went into cardiac arrest. She's in ICU right now, very, very severe. And we don't know what's going to happen."
So what happened next? You went up to the hospital?
Yes, so I was supposed to take care of my nieces and my son since she was at the hospital. And I ended up getting everybody to the babysitter. And then my uncle, my dad's brother, came over, and we drove up to Chicago together. And I remember getting there, and the first thing was like, I need to see her, I need to see her. And I wasn't able to see her for almost an hour because they were trying to put a chest tube in her, and they were having a really difficult time. And I remember just sitting there, like that 45 minutes was probably like 4 days, like it felt like. But I was not expecting at all to see what I saw.
And what did you see?
Just her hooked up to all kind of machines and not responsive at all. So,
And what was your impression then? Did you think she was very sick, but she was going to be okay? Or what were you thinking at that moment?
I definitely thought she was going to be okay because knowing that she went into cardiac arrest, I was like, well, what better place to be than in an operating room to go into cardiac arrest?
Yeah.
Like, you have the most immediate response. You're going to have the best results. I just figured it was going to take a little bit of time, for her to come around. But I definitely thought that she was going to be okay. And I remember trying to be supportive to my parents because they were kind of nervous and like, I'm not so sure it's going to be okay. And I remember trying to reassure them no, she had a heart attack and she's here at a hospital, and they were there immediately and they helped her, and she's going to be all right. She's young, she's 39.
Yeah. And so what had you been told at this point about what had happened to her?
So after I went in to see her, we came out in the waiting room, and shortly after that, the surgeon came out with, I think, 1 or 2 other people. And he would not make any eye contact with us whatsoever. He was basically like, well, she's stable right now. We need to just observe her and see what happens. We're not sure how much damage has been done. We just have to wait till she wakes up and kind of assess it. But his body language said everything, because as we're trying to ask him questions, because of course a million things are running to our mind, like this was supposed to be simple, and she's supposed to be in recovery talking to us right now, and we're at the complete opposite realm of what was supposed to happen. He wouldn't make eye contact, and he was rushing. Like, he was walking down the hallway as we're still trying to ask him questions, like, you're bothering me, it's 9 o'clock at night, I want to get out of here, you know, kind of thing. So we didn't have much information at all, and we just sat there as a family that night with 500 different possibilities running through our head.
Yeah. And your parents have been told immediately when the crisis happened, your parents have been told that she had had a heart attack, right, in the operating room. So when was the first time you met Tim or began to hear a different story about what had happened to Michelle?
I believe it was like 24 hours, Tim, which felt, again, like probably 24 days. We first met Tim and Nikki, and we went into a room together, my parents and myself and her husband, Chris. And Tim sat down and said, we're going to conduct a thorough investigation. We're not exactly sure of all the details, but there may have been a possible error. We need to interview a lot of the staff that was involved. We need to get a very clear picture of what happened. We don't want to give you any information that's not correct. So within a couple days, I'll be reaching back out to you. We'll sit down, we'll have another conversation, and I can give you, the exact details, pretty close to exact details of what happened. So right now I don't have a lot of answers for you, but I am going to be getting all of the answers and getting back with you.
And what was your family's impression when you heard there might have been a mistake?
Everybody's hearts dropped.
And tell me about the next interaction you had with him when he might have told you what had actually happened.
So a couple days later, when we met, again, I was still being positive and still thinking that she was going to pull through it, and reassuring my parents she was going to pull through it. But at the same time, I started to have a lot of doubts because she wasn't showing any signs of waking up. And so when we went to meet with him, my parents already pretty much had realized, no, this is not good, and it's not going to end well. So we walked into this meeting thinking, okay, we're going to meet with him. He's going to say, oh, we didn't make any mistakes. She had a heart attack. We're sorry, maybe. And just kind of leave us hanging with not accepting any of the blame or anything like that. So we were very skeptical going in, and my brother-in-law was very angry. I remember he wouldn't even look at Tim. So as Tim started to talk and Nikki started to talk as well, I could tell there was sincerity there. I remember we sat in the room for, I don't know, probably a few hours, it seemed like, and he gave us all the information. I spoke to this person and this happened, and that's when he started telling us, she received too much anesthesia too quickly, and she went into cardiac arrest, and they had to resuscitate her, and then they started doing CPR, and they stopped too soon. They thought her heart had started, and it wasn't until she turned blue and was like 7 minutes without oxygen that they realized that her heart didn't start. And right away we're like, the basic CPR is you check for a pulse. How did nobody in that room check for a pulse? You trusted a monitor. You looked at a monitor and saw a rhythm, and you thought my sister was alive, and you stopped. So it was hard. It was an emotional day. But at the same time, we were appreciative that he told us that. Because in Indiana, where we are, the local hospitals would just deny. And we would have never known the truth. So as much as it hurt, at least now it made sense what happened, because my sister was in very good health. It didn't make any sense that she was going to have a heart attack during surgery. So it was good to have the answers. So we were receptive to that, but then it was a whole nother realm of, okay, now we know for sure she's not going to come through with this, so how are we going to deal with this with her having a 7-year-old and a 1-year-old, and she went into the hospital on her first birthday, so she didn't even get to celebrate her first birthday with her.
So there's many other dramatic twists and turns to this story. It turns out that Michelle through some intervention by Tim, was able to donate her organs, and the organs it was a directed donation to a friend of the family. It was just incredibly dramatic set of circumstances. But I want to ask you, as time went on, what did it mean to your family that University of Illinois at Chicago told you the truth and came to a financial resolution? What did those things mean to your family?
Well, the start of that conversation was kind of the beginning of everything and to what we do today. And we went home, we planned her funeral. A large amount of staff, doctors, nurses who took care of my sister, drove to Indiana. It's about a 45-minute hour drive, came to her wake, came to her funeral. That was another turning point for us. You know, we realized Tim was sincere, but we're like, how sincere? Is he going to forget about us later? Is Michelle just going to be another person? But when they came there, we're like, wow, this is really impressive, this staff, that they care enough to take time out of their day to do this. And we spoke to Tim about the 1-year anniversary. And we were going to meet back a year after she had passed. And he was going to tell us ideas that he had. We could share some ideas with him of what we could do in honor of her name, because we didn't want her to die in vain. So we wanted to do something that would be helpful, that would help everybody, doctors and nurses and patients and ourselves, kind of heal from all of this. So a year to the day, Tim called. And I'll never forget when my parents told me they got that phone call. They're like, oh, guess who I talked to today? And I said, who? Tim McDonald. And I said, he remembered us? Like a year? He kept his word? He actually called us back? And she said, yeah, he wants to meet with us. And so some of the same doctors and nurses came into our area and went to a restaurant, and we sat down and we talked. And one of the suggestions he gave is, how about you sit on our medical review board? And you can meet with us once a month if you don't mind driving into Chicago, and we'll go over, some of these near misses and things like that. And we want your perspective. We want you to share with the doctors and the nurses, and know where you're coming from and how we can help you. And more importantly, how we could keep patients in the future safe, so there's not more cases like Michelle's that keep happening.
Thank you for telling your story, Chrissy. I know it's painful to have to tell this story, and I know Chrissy's parents as well, and it's just hard to imagine for those of us who have children what it might be like, or siblings, to have to come and tell this story of one of the worst days of your life. So we're so grateful for your sacrifice in doing this, and in honor of Michelle's memory. I want to leave a moment or two for people to ask questions if they have some questions, but would you like to make a closing remark about what should the people in this room take away from your experience and take back to their own hospitals about the importance of taking this approach to families after bad things happen?
I think at the end of the day, if you put yourself in their place and you think of that patient as one of your family members, I don't think you'll ever be able to fail them, because if that's your family member, you're going to give them the best possible care that you can give them. And if you can think of it in that idea, I think that's super, super helpful. And most important thing is the honesty, because if we would have been lied to and never known the truth, I wouldn't be standing here today. I would be a very angry person. I would probably be very scared to go to doctors and hospitals. So everybody's human. Everybody's going to make mistakes. However, just try to do everything in your power that you possibly can to keep the patients as safe as you can, and be very honest with them, and have the communication and reach out to patients. There's a lot of people, I'm sure, just like me, that would love to share their story. And it's healing for me, and it's healing for my parents. And even though it's difficult reliving it every single time, it's healing. And it makes me feel like we're making a difference. So I hope all of you remember my sister's story, and you think of her from time to time, and try to do the very best that you can, and keep working as hard as you are to make your hospital safer.
Thank you. Let's give Chrissy a round of applause. It's just so... I'll make one comment, and then we'll take time, maybe one or two questions before we move on. So sometimes people ask us, How long should we talk to a patient or family after a bad event? How long does a disclosure take? And our kind of standard answer is that disclosure to a patient and family after one of these events is a process. It's not a single event. We tend to think of that moment when we have to break the bad news, like that first conversation where Tim admitted that there had been mistakes made. We tend to think of that as the critical moment, and it is critical, but it goes on and on and on. And now, so Michelle, may she rest in peace, died in 2008. It's 2018. And Chrissy's still here, and her parents still come out and talk with us, so it's 10 years later. So the disclosure process sort of ends when the family's ready for it to end. And you stay engaged with them until they don't want to be engaged anymore. So maybe time for one or two questions. Questions for Chrissy about this experience or what we ought to learn from it? Yes, please.
So you said, I'm not sure if you said you or your parents sit on a board or sat on a board. Mm-hmm. Did you find that your perspective into increased safety was vastly different than maybe the perspective of people inside the hospital or with a medical background?
So myself and my parents do sit on it, all three of us. And eventually it's hopeful that my nieces want to get involved and they could take our spot. But I definitely think our perspective was different. And just as the doctors and nurses are probably a little intimidated to have us there, we were intimidated because I don't know that medical terminology. I'm a teacher. I know a lot of vocabulary, but I don't know medical terms. I don't have medical training. But from going there over and over again, you start to learn, and everybody can learn things. And Tim always made sure that we would come in like a half an hour early. He would debrief us about the cases we were going to be hearing. He would explain some of the terminology to us. So as we heard some of the words, we're like, okay, this word's familiar. And we always felt, and I think it's because of the way he prepped us and the way he would bring us into the conversations, we always felt like people wanted us there. We didn't feel like we were there and they were like, oh, we don't want to talk because they're here. We need to be quiet. We can't say certain things because they were here. And my dad and I, more so than my mom, we had no problem jumping in. Like there were times where like, okay, I know you guys have something to say, Bob or Chrissy. What do you guys want to say? So I found that people were welcome with it. I think it was a little nervous for everybody at first. But I think they appreciated it. A lot of people would come up to us after the meetings and thank us for coming and thank you for giving your perspective. Anytime you have more heads to brainstorm with, it's better. So, and especially things that we think of that you might. So it's nice to have those two different perspectives. You're welcome.
Okay, so Chrissy will be here there's one other question. Thank you.
Mm-hmm. Thank you. Thank you for your story, too, by the way. What, in your perspective, would be something we could tell patients to help encourage them to be on a team? Because you said you were a bit intimidated at first. What could we do to help a patient convince them to be on a team, like a medical review board? Maybe it's a question for both of you guys, but what did Tim tell you to get you to agree to be on it that we could use?
Well, he knew partly that we wanted to do something to honor my sister. He knows that I'm a teacher, so I'm used to speaking in front of people. My dad used to be a politician. He was the mayor of our city, so he's very comfortable speaking in front of people. But he told us he would give us the support with the meetings that we would have prior ahead of time where he would prep us on what things were going to be about. So that was super helpful versus walking into some situation, you don't know what they're going to be talking about. Do you understand half the things they're saying? We wouldn't have felt as easy to participate with it. So I think the whole debriefing that we had was the key, because you don't want anyone to be in a room and be like, well, we want you to participate, but here, we're going to talk about something you have no clue about. So he reassured us, we're going to have this time. I'll explain things to you. I'll bring you into the conversation at times when I feel that I need your feedback if you're not, raising your hand at that time. So though I don't know, he could probably explain it better. I just think he handled it very well. Do you think there's anything else you did that I didn't say?
Well, I got advice. And Tom, who I got advice from was Marty Hatley. So I went to Marty Hatley and I said, Marty, we really want to move forward to this full immersion in patient and family engagement. And again, this is 2008. So I talked to a lot of other advocates who advised to do what we did. which is, I think the most helpful, and you mentioned it, Chrissy, is meeting an hour before to go through the cases to explain the medical part. But the value they brought was incredible from, as we would call it, the conscience of the community. There was one time when we had, and I don't know, Chrissy, if you were there for that. I know your dad was, because I saw her respond. So we had a case of a retained neurosurgical object. And we were doing the event review. And the neurosurgeon literally said in the room, not knowing who the family was, you know what? I don't know why we're making such a big deal about this. SHIT happens.
Oh, yeah.
Well, her dad did not take that very well. And he didn't know who he was. And he leaned in. And it was brilliant the way that he oriented it to this notion that it's not just SHIT happens. Mm-hmm. We're here because that happened to our daughter. Mm-hmm. And underneath the table, you could hear everybody clapping. Because all too often, a lot of people say, hey, harm is part of doing business. And that was the value of them. The other part that your mom did is she would take notes. So 2 months later, when action plans were supposed to be finished and something came up, she would ask, so, Chief Nursing Officer, what's the status of what you promised 2 months ago? And that created, again, this awareness. And it really drove people. When they showed up, they knew they were going to get asked by one of the most important families that ever worked with the U of I. It was unbelievable how great it was. In fact, I mean, I have to share this, Chrissy. So years after, as you know, on the anniversary, it was, as you know, in April, your dad came in. And again, I don't know if were you there for that when he brought the 3 boxes,
Yes.
the 3 presents in?
Yes.
So he brings these 3 beautifully wrapped presents in, and he gives them out to Bonnie, who was the nurse who took care of Michelle in the ICU, Nikki. And when she says Nikki was the key real architect to the 7 pillars in Candor. She was the director of safety and risk management. She was the person I worked closely to create our hotline for responding to patient events, and we'll talk about that in a bit, but she was the one having the first conversations. And so he gives a present to Bonnie, a present to Nikki, and then he gives me a present, you know, thanking me for the conversations we had. And I promised him, and it's this amazing Movado watch, which has engraved on the back of it, Michelle Malizo Baylog, April 25th, 2008. And so I promised them, so we would not ever forget Michelle, I would bring this to every single significant patient safety conference we've had. And I've done that for all these years. I always carry it with me as a reminder. An amazing, you know, magnanimous, incredible family. And it's a real honor, Chrissy, to be with you, you know, as you know. We've been in several places, as you know, and it's just great to be with you here in Iowa.
Thank you for including me.
You bet.
So you go ahead, sit down. So Chrissy will be here all day today, continuing to be the conscience of the community and reflecting on everything we do today from the patient and family perspective.
Sure. Thanks, Bruce. The other part I want to explain a little bit on the medicine piece. When you talk about the CPR and how bad it went, what we learned in the interviews was that the anesthesia representative who showed up and the ED representative who showed up got into a physical fight about the way to respond to the cardiac arrest, which led to further delay in doing chest compressions. But before that, and this is the other part that is really critical to the whole Candor process, and why we'll get into this today about needing to have a super rapid response to harm, what we might call the GO team. Something happens, you call a hotline, these 3 groups come out, one of those who do the event review, one is going to lead the communication with the patient and family, and the other is going to make sure that care for the caregiver happens. In this case, the system worked, which is to say, during the cardiac arrest, our hotline went off, which is why our director of safety and risk management was there about 5 minutes after Michelle had gone up to the ICU. Why is responding so quickly so important in patient safety and in Candor and what we do? Why is the fact that she responded so quickly so critical in many situations? People forget. So part of the immediate interviews, absolutely critical to try to figure out what happened. What else is really super critical? Rapid responding to a tragic, catastrophic event. So supporting the family right away.
You start building that relationship.
Yep, so the goal is building trust. What about the event review? Why is responding so quickly so important? What's that? The team is all there who you can interview, but what else do you have access to that you won't have access to in 12 hours? The products, exactly. Don't turn the monitors off. There's a lot of data in there I'd like to take a look at. So that happened in this case. Nikki found in the trash 15 feet of rhythm strips that showed all the vital signs that were very different than what was in the official medical record. Because what had happened in this case actually is the nurse who was monitoring her went outside the room to go get another stent to put in and thought she'd hand it off to somebody else who didn't hear the handoff. After she left, Michelle stopped breathing. And what was in the trash, which was not part of the official medical record, was evidence that she had gone 7 minutes with an oxygen saturation under 50%. That's how I knew to tell them early on things had happened. But this is not part of the official medical record. You know, it wasn't labeled, you know, there wasn't timestamp, but we know it came from that case. So from the legal standpoint, we needed to make the decision, were we going to share something that would never be able to be obtained through subpoena with the family that showed how bad our care was? And fortunately, we had hardwired this approach. Our board was committed. The C-suite was committed. That's the part that we had to share. If Nikki doesn't show up immediately, we never have that information. That was the critical stuff. So again, that is the reason why the rapid response is so critical. So kind of leading in a little bit until I have Bruce, take over and talk about the communication assessment and communication, just some background. And again, leading in a bit to the legislation here is, the driver for this is, as we now know from this article that was published by Macri, if you look at preventable harm in hospitals, it's the third leading cause of death now. If it was its own diagnostic category, behind, just behind, cancer and heart disease. The problem is so often, as Tom talked about, and what we had at the U of I was the wall of silence that all too often goes up when these events happen, so that everybody suffers in silence. The families, the patients, the caregivers, the team, and the rest of it doing that. And so we had a case at the U of I years ago that drove this home, incredibly embarrassing. The former chief operating officer at Michael Reese Hospital came to the University of Illinois to have a plastic surgery procedure done. And as part of that, she ends up getting a CBC that shows a white count of 1,000. And so for the clinical people here, you see that's pretty low. For the non-clinical people, it is a red flag. And we completely missed it. Anesthesia missed it. Surgeons missed it. We completely did not see this. So she goes ahead, she has the surgery, and then her post-op CBC shows a white count less than 500, which is a critical test result, which got called to a Mary RN on our floor at a time there was no Mary RN. So we don't know who it went to. So we missed it again. And, she ends up, getting discharged from the hospital and dies 6 weeks later from a treatable leukemia at Northwestern. Again, this is the early 2000s. So at that time, we went to our leadership and said, hey, we'd like to reach out to the fiance. And they said, no way. This is the kind of the traditional delay, deny, and defend approach. And statistically, was there logic behind not communicating to patients and families about that? What were they thinking or hoping in our C-suite, in our board, in our legal office by saying, no, don't reach out to the family? What are they hoping? That it'll go away, right? Is that logical? Statistically, does that make sense? Statistically, does it make sense? It does. the data shows that about 85 to 90% of the time when negligent care happens and hurts somebody, families don't pursue it. They don't pursue it. In this case, it wasn't logical. And so because you have a medically oriented family, so what do you think they did? Yeah, they lawyered up and they sued us. And then what do you think we did? We lawyered up. We spent 4 years and $300,000 defending the indefensible, ultimately settling for millions of dollars, and tragically learned little, and we suffered immensely, from this process. It was horrible. But it is the case that drove us to change. When people really, because she was one of the top 100 women in healthcare. She's one of ours. And we lied to her family. And we're writing a book a little bit about this and some of the other stuff. There were 43 depositions taken in this case. So imagine, of medical students and resident physicians and nurses and others, imagine the hell they went through doing this. So a really bad way to do it. And as we talk about culture eats strategy for breakfast. So after this, we then put together, which forms kind of the foundation to Candor, these kind of principles, which now, and even hearing Tom, it's kind of hard to argue with these, which is number one, we will provide effective communication rapidly following all serious harm events. When we know our care is bad, we will apologize and find a way to resolve it. We will learn from this, and we will support patients, families, and caregivers throughout. This is the fundamental, the foundation to this approach to Candor. But this is how we first designed it. And what I love about this is we then took this in 2005 to a whole bunch of patient advocates, because this was going to be our process, when we redesigned it. So an event happens. If there's harm, we'll look into it. If it turns out our care is bad, then we will apologize and we will try to resolve this early, and we'll collect a lot of data. What do you think the patient advocates told us when we shared this with them? And I can tell you they were highly critical. What's missing from this picture? Sure, so there's nothing in here about all the near misses that we know we can learn from, and highly reliable organizations really focus a lot on that. So it's, what's that? Also, what are you doing to prevent it from occurring? Yeah, so there's no process improvement on there, is there? Right? There's none of that. There's no learning in here at all with that. What else is missing? What's that? So there's no peer support. There's no support for other people here. What else is missing from this part? So the patient's perspective in the event, which is a really good point, and we're really moving fast to try to make sure we incorporate the patient and family perspectives in that so we can learn from it. What else? So the other piece, yeah.
At what point do you tell them? I mean, you're not talking to the family until the very end.
Exactly. And in your organizations, how long does it take you to do your event review and figure out what happened? Pretty quick. You're done in about 12 hours, 18 hours. U of I, 2 months is a common way to really try to figure it out. So here's what we learned from families like the Melizos and a lot of other families. And this is what drove the paradigm shift for what we do. What we learned from them is every hour that goes by without effective communication, not apology, none of that, just without effective communication, following serious unexpected harm is another harm. Every hour that goes by is another harm. So I want you to think about this in terms of the Candor legislation and what the pieces are, because it's our belief that these early conversations, just explaining what's happening, not apologizing about mistakes, is absolutely critical to maintaining trust. And if you get to that point, as we'll talk about with the legislation, you want to have a conversation about it was a mistake and here's where it is, that's something to think about. But in the meantime, patients and families really want to have ongoing effective communication. Because as those delays happen, it's horrible. And that's how that drove a lot of what we did, and we know it had a huge impact on our outcomes in terms of doing that. The other part we don't talk about here is billing patients. I can tell you we did do a wrong-sided neurosurgery case once, and we billed the patient, and then we sent them to collections. That's not really good mismanagement strategy. So we also had to hardwire that to make sure that all the doctors were on board too, though. It's not just the hospital bills, but it's the professional fees and others. So we redesigned it, published it as the 7 pillars. So this is the diagram that led to a lot of the funding that we got, that we've had over the last several years about studying this and how it works. But you can see, event happens. Even in no harm events, there's near misses we try to look at and put into the queue. Support the second patient. We don't like the term second victim. Families don't like that. There is a victim. It's the family and what they did. So that's why we call it care for the caregiver. We hold the bills. Big part about activating crisis management, which means letting media know, media relations know, because some of these cases can have that kind of impact all the way through. And then, as we're going to really focus on this morning, creating this patient communication consult service. As you will hear from Bruce, like any other skill in life, there's a variation in terms of how skilled people are even in communication. And he will go, so we created a small group of super communicators who we could call on in these really tough cases, and it made all the difference in the world to either coach or help other people do this. Again, it was a big part of it, and we'll be getting into that in a bit. And then again, if it turns out care was bad, how do we disclose? How do we provide that apology that also includes some sort of remediation and connecting over to the process improvement? Ultimately, that led to funding that led to the Candor toolkit that came out in May of 2016, which has all of these dimensions in here that we'll be talking about over the course of all the workshops we're going to do. Today, the big one is focused on that response and communication. You hear about an event, you now need to communicate, and you need to provide peer support. And that'll be the focus today. The other workshops will be on human factors event reviews. When we do those workshops, we have mock medical records you'll be able to go through. You'll be taught about cognitive interviewing. And so how do you find out from people what really happened? All the way down to how do we resolve these cases and how do you hardwire it and put it all together. So this is the paradigm shift. You know, moving from where we were, as you can see, where reporting happens immediately. You know, I don't know what your systems are, but all too often we had Midas at the time, and so people would put in a Midas report, but you wouldn't know about the event till the next day you came in and logged in. So we created a hotline so people could call it and get help immediately 24/7 for people who could, again, manage the Go team. You know, the group of people who may respond, start the event review, or help with the communication piece. And then all this rest of this paradigm shift, as Bruce will get into, this whole communication to immediate and ongoing, and then care for the caregiver from suffering in isolation to providing immediate support. So what about the data? We've published many, many papers around this. Our event reporting went from about 2,500 a year to 14,000 by the time we were done. 3,000 of those were from resident physicians. Getting the residents involved in this was critical for us from that standpoint. Claims went down. We saved a ton of money. The other paper that we published showed that there was a significant decrease in the practice of defensive medicine for the physicians who were involved in doing this sort of work. The other key piece is time to resolution. When we started this, and we were already seeing a decrease, it was, and I don't know about what your times would be, but it was often 4 years from the time of an event till some sort of at least legal resolution related to it. When I left the U of I, our time from event to resolution was about 9 months, which meant a lot less suffering for the people who had to go through those pieces of it. So now in the context of the Iowa Candor legislation, you know, the bill, as you can see, Tom, how did you get unanimous passage of this? No, but I mean, seriously, that's staggering in this day and age that politically you're able to do that. And then now, obviously, you expanded a little bit. But can you talk a little bit about the legislation in the context of what we're talking about? And what I'd really like to get to is, when do you recommend that people trigger it versus, you know, continue to have effective communication? And then at some point, you got to figure out how do we now get into that process of the consent piece and the rest of it? Could you?
I'm Dennis Tibbin. I'm the Director of Government Affairs for the Iowa Medical Society. So we were the lead on passing this legislation. And I'll turn it over to Kate for some of the more specifics, but as far as the question about unanimous passage, we were very proud of that. We worked out this legislation in conjunction with the trial attorneys. So it was very much a consensus bill. It was something that both sides were supportive of, something that the folks that would normally be up there fighting against us felt that this was a good approach, that this, while it would end up costing them some business because they would not be going through the lawsuits that they normally would, they still felt it was the right thing to do. So they were all on board from the get-go.
Hi, everyone. I'm Kate Strickler. I'm the general counsel for the Iowa Medical Society. I started with the Medical Society right when we started to look into getting this bill passed. So I know Dr. Evans mentioned the Iowa Apology Law, which allows providers to apologize to patients. I know that this bill was well-intentioned, and I know that the Medical Society worked on it, but it was written very narrowly. So, for example, if you tell someone, I'm sorry that I gave you the wrong medication, that's actually still admissible in court because there's an admission of wrongdoing. The only thing that a provider can say is, I'm sorry you're experiencing discomfort. I'm sorry that this happened. Very generic and more or less vague apologies. Another thing that we learned from working with the trial attorneys is that the trial attorneys who represented the providers were actually encouraging them to apologize in a way that would be admissible in court, because the jurors were harsher on physicians who had not apologized than they were on physicians who had. So the Medical Society with some other organizations put a lot of work into this Iowa apology law, and it really wasn't being used at all. So we met with providers, we met with patients, we met with all kinds of interested stakeholders, including the trial attorneys, which was interesting. We came up with the Candor law with a lot of discussions. I think Dr. McDonald even came to talk to IMS about what was working in other states and help guide us with drafting the law itself. So the law itself actually allows for providers to have a confidential discussion with patients after an adverse health event. So that means that when a provider engages a patient in this confidential discussion, if the case does proceed to litigation, that conversation is not admissible. So it really provides a safe space for providers to be very open with what happened, to be honest about everything that went wrong, to let the patients ask all of the questions that they have and to get honest answers. There are some specific provisions in the law that sort of trigger this protection. So for example, before the Candor protections apply, the provider must give some disclosure forms to the patient, just letting them know what the statute of limitations is to bring a case, to encourage them to get an attorney, to let them know that they have a right to an attorney, which actually the providers have found that having an attorney in the room sometimes helps manage expectations of the patients. So attorneys are always welcome. I'm not just saying that because I am an attorney. The alternative solutions to traditional settlement amounts are almost always on the table. So instead of just figuring out what amount will make a patient or the patient's family feel better, they also discuss things that can be improved in the system so that this doesn't happen again. And sometimes there are non-traditional resolutions that people want. For example, there was a case here in Iowa at our pilot program where a woman presented at the emergency department with some high blood pressure. She wasn't feeling great. She was also pregnant. She was not referred to the OBGYN department, so she didn't see anyone in obstetrics until I believe she'd been in the emergency department for 9 hours. Ultimately, the infant was stillborn that day. In addition to the traditional settlement, she also wanted a memorial in the hospital for stillborn babies. So that's something that never would have come up in a traditional lawsuit. This was a way for her to get some closure, for her to help other people who were going to be in her situation to be able to find some sort of peace. There's now a section in the hospital where you can go and see this memorial to the stillborn babies at that hospital and everywhere. So the pilot program that I just mentioned is in Southeast Iowa. They have gone through about a dozen cases now. They've been up and running for almost 2 years. Of those dozen cases, only one has proceeded to litigation. They take cases through the Candor program where there is harm and where there is not harm. the way that the law is drafted here, the candor protections only apply when there's an adverse medical outcome, but that adverse medical outcome doesn't have to be as a result of medical error only. So I know this is a lot of information and it can be a little boring. So you have some handouts that give you some specifics. In addition, the Iowa Medical Society has an entire section on the website dedicated to candor. It has resources for providers, for risk managers, for anyone interested in getting a candor program set up. In addition, we have some physicians through the Medical Society, and our president will go speak to any hospital across Iowa if you want some more information and to get a more tailored presentation. So if you're interested in that, please let me know. I will also provide my email address to everyone. I believe it's on one of the handouts. So if you have any specific questions, please feel free to let me know. If there's any questions right now, too, I'm also happy to answer if time allows.
So I have a quick one, which is important practically, which is, and you're going to see this in the cases that we're going to enact here. So a lot of times there's harm events, and we have no clue whether we've made a mistake or not. But the family wants that effective communication. So is there any kind of general guideline about when do you now take advantage of the statute and do the, sort of go through the process of the consent piece? Because one of my concerns would be, if I do it right away after medication error, that's going to be maybe awkward. So do you have any advice or general guidelines about, okay, because it's kind of the question that you brought up here. What would you suggest?
Well, the way that it's worked at our pilot site is that they have the consent forms ready to go, so they immediately send the risk management team to talk to the family. So sometimes the risk management team shows up and they're not completely sure what's happened because that investigation is ongoing. That's going on at the same time, and so the risk management team can say, we don't know what happened, we're looking into it, we'll let you know as soon as we do. We want to talk to you about this, so here's some forms that we want to go ahead and sort of get out of the way. So they do give those forms immediately, because even if the candor discussion doesn't actually happen within the context of this law, that's still information that it's good information for the patient to have, to know what their rights are as patients, to know what their rights are as family members. And the paperwork is written in such a way that you don't need a law degree or a medical degree to understand it. We wrote it. It's very basic. We have those forms on our website as well, and I think it's written at a third grade level, so anyone can read through it pretty quickly and understand. So the way that the pilot program has addressed that is to get the forms out of the way regardless of what ends up happening, sometimes before they even know exactly what has happened. But of course, we would work with any institution to try to figure out what would work within your infrastructure to tailor it to what works best for you.
So what would happen if the family says, hey, I'm a little nervous, I want to talk to a lawyer first or whatever before I sign this piece? What about again, there's this need for communication because, grandma fell and she broke her leg and she's now going to the OR. What?
So we haven't run into that in our pilot program yet, but we did discuss that option, what would happen. And the chief medical officer, who's the person who's really been very involved in this, went back to his board and told his board, if they don't sign the forms, if we're not under the candor protections, I want to go forward anyway. It's the right thing to do. It's definitely right for the patients, it's right for the provider, it's probably right for the board too, because once you've been through this discussion, so few things actually proceed to litigation anyway. And ultimately the board agreed. So if the patients won't sign it, they still move forward as though the patient had.
Okay. Interesting. We can talk a little bit about that. When we do the enactments and the training, it's in the context that the forms are out of the way. The focus now is how do you provide the effective communication? Because I don't want to get into the legal, not licensed in Iowa. I am in Illinois, but it's important to think about this because a lot of attending physicians just want to go in and have the conversation with the nurse and aren't necessarily thinking about, boy, I better get the risk manager in here, with me,
Right.
from that standpoint. So.
Absolutely. And the pilot program did a lot of training with their risk management staff on communications. Dr. McDonald spoke at a presentation in Palo Alto, California that they sent their entire risk management team to learn how to communicate with providers and with patients more effectively.
All right. Thank you.
Thank
So Bruce, you want to come up, and we're now going to move into the communication assessment and empathic communication before we take our first break.
Thank you, Tim. Could I have the clicker, please? Yep. Thank you so much. So what we want to talk about now is the communication assessment and our first kind of didactic portion of the day about communication skills and how you respond to patients and families. And some of the same principles will apply to how you respond to your colleagues who may have been traumatized by being present when serious errors occur. So one of the main differences between the old way of doing things and the new way of doing things is we want to move our communication strategy from deny and defend to immediate and ongoing communication with patients and families. And as Tim mentioned, just like any other skill, just like our athletic ability or our intelligence or our height or our weight or any other characteristic of human beings, there will be a normal distribution. And by definition, the vast majority of us will be near the center, right? Most people are average by definition. But some people are extraordinary. And so these communications with patients and families after serious harm are very, very difficult conversations to have. Most of us are not trained to do them. Most of us are not skilled enough to do them. But some of us are extraordinarily skilled. So the idea behind the communication assessment is to try to identify the most highly skilled people in your organization, put them out front, empower them to take leadership roles so they can have these conversations with patients and families under the most difficult circumstances. So because all of us can communicate, right? All of us can speak English. Maybe some of us speak a couple different languages. We're adults. You're successful in your career. So everyone thinks they're a good communicator. This is just one of those things. I think it's like Lake Wobegon, right? Where all of the men are handsome, the women are good looking, and then all the children are above average. I got that a little bit wrong, but right, all the children are above average. Well, we can't all be above average. It can't work that way. There's these famous studies of driving. When you ask people about their driving skills, and 85% of the people who respond say that they're an above average driver, right? It can't be that way. So this is an illustration in the realm of athletics that we're not all, even some of us who might be skilled at athletics, when you compare us to the very best, we're not all that good. Could you roll that tape, please?
All right, get to the money shots now.
All right, simulcams time. This is when it's always fun, right?
Yeah.
Why don't we start out with perhaps the number one pick in the draft, Jameis Winston, the quarterback from Florida State, the Heisman Trophy winner. Jameis ran 4.97, Rich.
ESPN, running the 40-yard dash against NFL draftees.
Well, what about the number two quarterback, or maybe the number one quarterback, Marcus Mariota, who ran the fastest time as a quarterback? And we gave you a little bit of a head start there.
You're gonna run me down. Oh, Rich, you almost had it.
Marcus ran 4.52, Rich, so don't feel bad about it.
Rich, you almost had it, man.
You get a 10-yard head start on this one. No. Kevin White from West Virginia, the wide receiver.
Oh, I have
10
no
yards
shot.
for you, Rich.
I have no shot.
And here comes Kevin.
He jumped.
Now, Kevin did run 4.35.
They didn't get Rich 10 yards.
We're going to go to 15 yards, Rich.
For Kevin what?
15.
15
Philip
yards?
Dorsett from the University of Miami, the wide receiver. You're getting 15. Run, Rich.
No, they didn't get
Stand up and
real
run.
15. That's not right. They didn't
And
get 15.
Dorsett, 4.33. So that's a bit of a problem for you there. Okay. Well, how about the UAB Blazer?
The
J.J.
fastest
Nelson,
one of the combine. I better get a 20
weighs about 105 pounds. And Rich, they said they gave you 15 yards on this. And J.J. Nelson ran 4.28. Okay, let's go to the big boys. You know you like
now they're just trying to humiliate him here.
Let's go to Leonard Williams from USC.
Leonard Williams.
And let's see how we did with Leonard Williams.
Oh man.
Leonard Williams, 302 pounds, ran 4.
So what's the point of this? It's kind of amusing, but what does it show? It shows that there's nothing wrong with Rich Eisen. He's a perfectly good athlete. If it was me running against Rich Eisen, he'd probably outrun me. But when you put Rich Eisen against a world-class athlete, there's no comparison. So I want to try to draw an analogy. So there's nothing wrong with your communication skills, right? There's nothing wrong with you as a person. But if you compare yourself to the very best communicator in your organization, there'll be no comparison. They're quantum level better than you, or maybe you are that person. And the reason this is so important is that disclosure situations are so hard. And so they really demand that we put our best people in these positions if we want to be successful. And they're hard for several reasons. There are multiple conflicting goals. We want to tell the truth, and we want to protect our own reputation, and we want to minimize medical liability risk, and we want to talk to people quickly. All of these goals tend to conflict with one another, especially tell the truth and protect my own reputation. If the truth is I made a mistake, these are conflicting goals, and it's hard to produce messages that simultaneously achieve conflicting goals. There's a high level of emotional arousal. We're very, very anxious, afraid, nervous, frightened, hurt, freaked out, etc., under these circumstances. There's a lot of ego involvement. Physicians and nurses and other medical professionals, their identities are very much tied up with the idea of being a competent, capable provider who doesn't make mistakes. So when you have to admit making a mistake, especially, it's very hard on your ego to do so, and that makes these situations difficult. And they're highly consequential. People's lives are at stake, literally, their careers, their medical licenses, millions of dollars, the reputations of lots of different people. That's what makes them so difficult. And we know in general, as one of your colleagues from the Iowa Medical Society already said, that it's often communication skill that predicts malpractice risk, not the severity of the underlying incident. It isn't the severity of the incident that's most correlated with being sued. It's how well did the communication go. All of this underscores the need to identify the organization's best communicators. So what we did for you, raise your hand if you did the communication assessment. Oh, great. That's the majority of you. Thank you so much for taking the time to do that. So this is a skill with an assessment with a long history. It's been used for almost 50 years. It was developed by a psychologist named George Kelly, who was at the University of Kansas. And it allows us to do a preliminary assessment of your communication skill. But in order to understand what it means, I have to give you a quick course in communication theory. So the people who developed this measure were trying to explain the development of communication skill from childhood to adolescence. How many people have children? So if you've had children, you realize they actually develop. They're tiny when they come out, and they grow, and then their skills develop. They don't speak at all, and then they acquire language. And once they acquire language, then they get more and more skillful using it. By the time they're teenagers, they're too damn skillful at using language, right? So there's this development of skill at communication from childhood to adolescence into adulthood. And theoretically, it was unexplained. How do children do this? Not just the language acquisition, but especially their skill at producing strategic messages and so on. So these scientists are trying to explain it, and they relied on a theory called constructivism. And constructivism says we represent the world internally in terms of these two-dimensional, or bipolar. Bipolar meaning they have two ends, like a North Pole and a South Pole, right? These dimensions that we use to represent other people in social situations. So a construct is a bipolar dimension for representing other people or social situations. And they can be things as simple as kind, cruel, fair, unfair, happy, unhappy, considerate, inconsiderate, and so on and so forth. Even tall, short, and so on and so forth. So our head is full of these dimensions for representing other people. And these are called constructs. And constructivism says that there is a psychological trait which we possess, which they call cognitive complexity, which refers basically to the number of these dimensions that we have, to their abstractness. So something like compassionate, not compassionate, or considerate, inconsiderate is a more abstract dimension than tall, short, or even kind, cruel. So these dimensions can vary in their abstractness, and we can have more or fewer of these dimensions. And they can also vary in their integration, the extent to which they're kind of connected to one another. And all of these are developmental progressions. You develop from few to more, from concrete to abstract, and from isolated to integrated impressions. And all that refers to cognitive complexity. So what we were measuring in the first part of the assessment when you gave these impressions of other people was cognitive complexity. And I want to give you an analogy. This is the image resolution page from Wikipedia. And on the far left, you have a 1-by-1 pixel image, which you can't tell what it is at all. It just looks like a blank image. On the far right, you get a 100-by-100 or 10,000 pixel image, and suddenly the image is clear exactly what it is. So the idea is that with low cognitive complexity, it's like having a low resolution image of the social world in your head. With high cognitive complexity, it's like having a high resolution image of the social world in your head. So it's not surprising that people who have a high resolution representation of the social world actually navigate the social world more effectively because they see it more clearly, and including all of its pitfalls. You've probably known people, and maybe you're one of those people, who can just see more deeply into social situations. They seem to see every possible nuance of a situation, where you also probably know people, sadly, who don't see any of the nuances in a social situation, who fail to see even the obvious aspects of a social situation, and therefore are unable to navigate or produce effective messages because they're sort of blind to the circumstances. So cognitive complexity gives us high-resolution images of the social world. So, I must have gone backwards. So as the quality of our social perception increases as we get more and more constructs and as they become more abstract and integrated. So the analogy I want you to think of is from having a low definition black and white image of the social world to having a high definition color image of the social world, and consequently having a higher level of skill and better ability to navigate. I use this metaphor of having a better map of the social world allows us to navigate the social world more effectively. So what we're sort of trying to measure when we give you this task is how high resolution is your own personal map of the social world. So we had you do this task. We said, in as much detail as possible, in only 5 minutes, think of a person you know well and like, and a person you know well and dislike, and describe them each in as much detail as you can. All we did then is just code them. We just count up the number of constructs. There's many ways to code these. You can code for abstractness, you can code for integration, but the most common way of scoring your impressions is just to count the number of adjectives, basically, that you use. How many distinct dimensions did you use to describe these two other people? We add them up, and that score, which you'll see on your results, which Tim handed out to you, on the cognitive complexity part, is your cognitive complexity. So I'll give you some examples of low complexity impressions. So genuine and sincere, that's genuine and sincere, that's two constructs. Taking people at face value, giving them the benefit of the doubt until they prove otherwise, strong work ethic, and team-oriented. That's 6 dimensions they use to describe that person. The next one, accepts blame, acknowledges others' achievements, level-headed, and trustworthy. That's 4 dimensions. And remember, for each of these, they're bipolar dimensions. So accepts blame, doesn't accept blame. Acknowledges others' achievements, doesn't acknowledge others' achievements. Trustworthy, and what's the opposite of trustworthy? Not trustworthy, liar, incredible, something like that. Good listener, not a good listener. Only 1 dimension. Now, when people give us that few constructs, when they're doing it online, we often feel like they were probably just busy, and they got this survey link, and they were too busy to do it, and they just kind of phoned it in. So we don't think that person really only saw every person in the world as just a good listener or not a good listener. They didn't have any other dimensions, but they didn't. And this final one, narcissistic moron. That's actually 2 dimensions. A narcissist, not a narcissist, moron, not a moron. So those are low complexity impressions. This is a high complexity impression. This is a real impression we got of a liked other. Intelligent, intellectual, relaxed, down to earth, approachable, genuine, etc., 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 comforting, faithful, motivational, introspective, pondering, committed, bohemian, adventuresome, generous, articulate. 47 dimensions. So what I want you to do now is think of the person who produced this impression and compare them to the person who produced this impression. Do you think they're inhabiting the same social world? Would you predict they're equally skillful communicators, right? The person who produced this impression, you think they might be a good communicator? Versus the person who produced this impression. Who would you rather have going to talk to a patient and family after a serious harm event? So there's lots of research in social science going back 50 years showing that people who produce more complex impressions like this are also better communicators. And this is a frequency distribution of actual cognitive complexity scores from about 430 people. This is about a year old now. We probably have twice this many impressions. We just haven't updated the graph. So it's kind of a normal distribution. It's skewed a little bit to the right. And as we would expect, most people have about 20 constructs across the 2 people that they describe. So if you had around 20, you're about average. Okay? And that even if you had between 15 and 25 years, this is most of us fall in there by definition. But over here, there's some freak mutant who had like 150 constructs. And even here, we have people 75, 80, 85. Tim, I went back and found my own score. I was at 50 or 52 or something like that. And here I am teaching you. If someone's here like at 75 or 80, maybe you should come up and teach. But these people are going to tend to be very, very good communicators. We want to identify them if we can, put them in positions of leadership to talk to patients and families under the worst circumstances and to comfort colleagues who have been traumatized. So as cognitive complexity increases, people produce increasingly person-centered messages. A person-centered message is one that's adapted to the needs, beliefs, preferences, attitudes of the other person. So communication, the most fundamental principle of communication skill is adapting our messages to the audience. So what high cognitive complexity allows people to do is to see deeply into other people and into situations and adapt their messages accordingly. So what we find, the research also shows that as person-centeredness increases, people perceive those messages as more effective, more comforting, more persuasive, just overall as better messages. So person-centeredness is a highly desirable characteristic of messages, and person-centeredness increases as cognitive complexity increases. So the second part of the assessment asks you to produce messages in response to two hypothetical situations. One, the Ron situation where you're in a group project and you're the leader, and Ron is a member of your group and he's not been pulling his own weight, and you have to kind of get Ron to do his work. Now, we can score these messages in terms of their person-centeredness, sort of, or in terms of something that we call message design logic. Message design logic is another theory of the development of communication skill, and it says that from childhood to adulthood, we tend to progress through different ways of thinking about the logic of message design. In the beginning, as children, we just think language is a tool for expressing our thoughts and emotions. And the goal is just to express them in an unimpeded, clear fashion. So this is children, right? So I give the example often as I was walking in the grocery store with my daughter once, and we saw someone at the grocery store had a limb amputated. And my daughter just looked at me and in a loud voice said, "Daddy, Daddy, she has no arm." Right? That's a child. The child is just thinking about expressing their thoughts publicly. Or the other example I often think of is that in the play and the movie, The Miracle Worker, about Helen Keller, who was born without the ability to speak or see or hear, the most dramatic scene in The Miracle Worker is when? Water. When she's feeling the water in her hand, she finally realizes she can use sign language to express her thoughts. She just acquired the expressive logic of message design. But as adults, we actually learn there's a lot of stuff we're thinking that's better left unsaid. Imagine if you could read people's thoughts. Wouldn't it be horrible if you could read people's thoughts? Imagine all the thoughts you've ever had that you just shouldn't be expressed at all. But you know people, unfortunately, who have gotten to adulthood and they still think that if they're thinking it, it's relevant to say. But it's not actually. Relevance is a socially constrained thing. So the second level of developmental skill is when we acquire this conventional logic, and that is communication is a game played by social rules. And rather than designing our messages so they simply express all of our thoughts in an unimpeded way, the conventional logic says we should produce a message which is appropriate to the context. So someone with a conventional logic will be very attentive to the context. What is my social role? What do the rules say I should say? What would be the appropriate thing given this context? And that's where most of us would tend to lie. But some of us progress even further and acquire this rhetorical logic, because some of us realize that there are these rules, but the rules themselves are shaped by language and can be reshaped in social interaction. Now, we often use the term rhetoric in a pejorative way. We think about politicians who use mere rhetoric. Or often when we think politicians are lying, we use the word, that's just rhetoric, right? They're saying it as if saying it made it true. But what the rhetorical message producer realizes that in some sense, in ordinary social situations, saying it does make it true. That the social world is in fact constituted by talk. And you can reshape the definition of situations, people's roles, people's goals by using language. And so we scored your messages as either reflecting an expressive, conventional, or rhetorical logic of message design. So the most skillful will get a rhetorical score and then conventional and expressive. So here's an example of a highly person-centered message to give you an example of what a good one looks like. And then there's a lot to say here. There's kind of a full slide, and you've got it on your paper, so I won't read it all. But some of the nice elements of it say, I have an update about the procedure Mary had, an update that's going to be difficult to share and maybe overwhelming to hear. So this is a part of the message that's adapted to the audience, that acknowledges that the news you're about to give is going to be difficult to hear. You'd be surprised, but the overwhelming majority of messages don't include any element like this, even though it's such an effective element. And then later on it says things like, we have a special team of people who walk alongside patients and families when there's an unexpected event. We'll be walking alongside with you as well. This is sort of non-abandonment. I see your tears. This is hard to hear. We don't yet have all the information, but we'll be reviewing that. And expresses uncertainty. It pledges to stay connected and not to abandon the family. So these are just examples of some desirable characteristics. You can go online and look for the Communication Assessment Guide on the Candor Toolkit website and find a detailed description of how we coded your messages. Here's some not so person-centered messages. There appear to have been some complications with the procedure, and the team's now working on Mary, as yet we don't know what the outcome will be. There's nothing horrible about that. It just doesn't say very much. Imagine if you were Mary's family and that's all that you heard. It seems like there's more to say. There's no empathy in it, really. And then here's another less person-centered message. Mary's heart rate got low, and as a precaution, the Code Blue team was called, Mary's out of danger now and will be fine. Well, Mary's in the ICU, unconscious, intubated, was not breathing for 7 minutes. We could argue about whether or not this is even a truthful message, much less effective. But actually, this is not an uncommon message we see in this situation, because we think people who produce this message are really dealing with their own anxiety. They're not very focused on the family and what they need to hear. They're focused on their own need to reassure themselves. So in summary, people differ in their ability to perceive social situations and produce effective messages. These differences are most apparent in difficult situations. In really easy situations, more and less skilled people are going to perform about the same. The skill differences are only going to become apparent when you have a really difficult task. We can measure these skills, and I described how we measure them in this assessment task. Highly skilled communicators are good candidates for leadership roles. If you didn't score at the very top of this distribution, if your message was scored as conventional or expressive, not to worry. We still absolutely need you to be part of the Candor team. And one of the most critical roles you can play, you may not be chosen to be in a leadership role. It may not be you who goes in to talk to the patient and family in these critical situations. And you may have a sense that that isn't your strength. But there's a huddle that precedes all these difficult communication situations. And what we find is, regardless of people's communication skills, everyone can make critical contributions to these huddles. And the communicators who do go in need their colleagues in these huddles to help them think of what questions are going to come up, what feelings might come up, what should I tell them, who should we send in, when should we have this conversation. So everyone is needed to make Candor work. And we don't want people to get the mistaken impression that if you didn't score at the very top of this distribution, that somehow you don't have a role in Candor. Nothing could be further from the truth. So I want to talk now about empathy, because we want to move the communication paradigm, this immediate and ongoing and empathic way of responding to patients and families, and ultimately to our colleagues and caregivers as well. So here's a definition of empathy that I really like from a book by Carla McLaren called The Art of Empathy. If you're interested in empathy as a topic, I highly recommend this book. It's one of the most in-depth studies of empathy that I've ever read, and I especially like her definition, and I'll tell you why. So Carla says, empathy is a social and emotional skill. So that's the first thing. It's social and it's emotional. A lot of us think that empathy is just basically that gut feeling, that empathy is like feeling people's feelings. And that's what empathy is mostly about. That's only a tiny part of it. It's a social skill, too. So that means understanding all these other things about the situation, not just people's feelings. And it's a skill, meaning it's learnable. How many people before you came in today, or even now, think you either got it or you don't? Empathy. It's like, blue eyes or brown eyes. You're sort of born with it. How many people thought that about empathy? Nobody wants to admit that now because I just told you it was a skill. It's a skill. It's a learnable skill. So we can learn the skill of empathy, and that's what this training is about today. We think that there are really concrete, learnable skills, and they're not that difficult to acquire. Tim and I often see dramatic progress in a day and a half of training. So it helps us feel and understand emotions. So it's cognitive and emotional. We feel and we understand emotions, circumstances, intentions, thoughts, and needs of others. So it's not only about emotions, it's about thoughts, plans, needs, goals, and so on and so forth. That's the cognitive part, such that we can offer sensitive and perceptive and appropriate communication support. This is the action part of empathy. It's not enough just to feel how people are feeling. You have to actually take action. Empathy is an action-oriented thing. It's doing something for other people. So you have to have altruism, the desire to do good for other people, and you have to have the ability to take compassionate action. So these are the aspects of empathy that Carla McLaren talks about. She says emotional contagion, that's the ability to feel other people's feelings. Most of us are just born with that. Empathic accuracy, the ability to accurately identify what people are feeling. Is someone feeling anger or is that frustration? These are slightly shaded things. Is it fear or is it anxiety? Right? Is it joy? Is it awe? Is it happiness? Is it surprise? And empathic accuracy is the ability to discern the difference between these slightly different shades of emotion. Emotional regulation is so critical, I think, for health professionals. It's about the ability to manage our own emotional response in a highly emotional situation. And I think all health professionals who have practiced for a long time have some ability to emotionally regulate, because you constantly face a lot of stressful situations. You see patients in a great deal of pain and suffering. You've witnessed a lot of death and despair and fear. So you have probably mastered to a certain extent your own emotions. But the question is, in what way have you done it? Have you done it by just completely compartmentalizing and shutting off your emotions? I don't think that's productive over the long run, though I understand how it's rational in the short run. So emotional regulation is about sort of having done your own emotional work such that when confronted with intense grief, intense pain, intense sorrow, or intense anger, you won't be so triggered by it that you can't function. You have enough mastery of your own emotions that you can be open to other people's and not be flooded by your own grief or sorrow or pain. Perspective taking, that's the cognitive part, knowing people's thoughts, plans, goals, intentions, etc. Concern for others, this is the altruism. So I often say that if you have the first four, you could be an evil genius, right? You could be a psychopath and have the first four. If you don't have concern for others, those skills are going to be wasted. You have to actually have altruism, the desire to help people, to do good. So you can put all those other skills to work. And perceptive engagement is sort of the action-oriented part, the actual ability to take effective action and offer people compassion, comfort, and so on and so forth. So this is a nice video by Brené Brown talking about the difference between empathy and sympathy. I don't think that vocabulary word distinction is critical, but she makes other observations in here which are absolutely essential. Please roll it.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So what we love about that is, I'm going to go back one second, is there's several observations. First, that empathy is a vulnerable choice. So to empathize with people, you've got to be able to connect to that same sort of feeling in yourself in a way that's emotionally regulated, right? So if someone is grieving and you want to comfort them in their grief, you have to be in touch with your own grief. Not so much that your grief overwhelms you and you can't function and you break down crying, but so that you remember what the grief was like and that you can connect with them in that moment of their grief. So it requires vulnerability. And this vulnerability can be painful if you've witnessed a tremendous amount of loss and sadness and pain and suffering in your own life. The second, I think, is that often a response can't fix anything, right? So if someone has died, there's been a terrible loss, we can't bring them back with our words. So it's just the connection, the being present with other people is what seems to have the healing power. So when you come up here later today and you try to empathize with some patients and families and with some caregivers who are played by actors, think about that. Think about making this vulnerable choice to be present, and also that connection is the main goal. Not some magic word that you're going to say, but the idea of being present with them in their experience. So this stuff about at least, nobody says that, right? Nobody's bad enough to say at least, are they? Anybody had that at least said to them? Yeah, people say this sometimes. So this is a message that Tim got from an acquaintance of his who had twins or two kids, and one of the kids had a congenital birth defect and died in surgery from the congenital defect. So this is a message, comforting message from a friend to this woman. Yes, doing well. A mother's heart longs when she is without her child. That's a perfectly empathic statement. That's lovely. Had she stopped there, it would have been perfect. But what does she say next? At least, at least you have your others, though, and they need to be happy. She had other children. At least you have your others, though, and they need to be happy. Be happy, okay? So I see people shaking their heads and cringing. Why is this such a cringeworthy thing to say? What's wrong with that? There's no doubt in my mind this person intended to comfort their friend. No doubt in their mind they were sincere in their desire to help their friend. So what's so bad about that? Yeah, they sort of the first person, and then they kind of negate it and minimize it. What else is wrong with it? Can you think of other things that are wrong with it? You need to be happy. So one of the anti-empathic things you can do is tell people how to feel. If you just want to annoy people and not be empathic, someone you don't like, just tell them how to feel. And that's like the worst possible thing you can do to someone. So the goal when you're giving empathy is to be right there with them, to say yes to all their feelings. If someone is grieving, our acknowledging their grief doesn't make their grief any worse. They're already grieving, right? If you imagine when you've lost someone that you loved, nothing's going to make you feel worse. If they acknowledge your grief, you're going to feel witnessed, feel validated. So we want to say yes to people's emotions, and this says no. So how do we ease people's suffering? Connection, that's the primary thing. Simply being present with people when they're suffering tends to make them feel better. And acknowledging our own vulnerability. Bearing witness to their pain. Often there's very little that we can do other than bear witness and let them know that their suffering is real, it's valid, we see it. It's not invisible. So it's the opposite of negating it, right? It's like validating that it's real. Invite exploration and expression and elaboration of their feelings. So this is because our feelings are so powerful and so visceral, we actually don't know what we're feeling. It seems ironic or hard to believe, but if you've ever had really intense emotions, it takes a long time to make sense of them. You don't know exactly what you're feeling. It's kind of a diffuse sense of feeling terrible, but expressing them, elaborating them, helps us actually put language to them and make sense of them. This is a favor we can do to people who are suffering. And then acknowledging without judgment the depth and complexity of what people are feeling. This is an additional way of validating. And not judging. People are allowed to feel whatever they want to feel. How many of you were brought up in a household where some feelings were off limits? There were good feelings and there were bad feelings. There were feelings you were allowed to have and there were feelings you were not allowed to have. Raise your hand if in your family there were some feelings you're not allowed to have. Okay, so tell me, what feelings were off limits in your household? What did someone say? All of them? Oh, all of them. I'm so sorry. See me afterwards. Which ones were you going to say? You couldn't feel bad. You couldn't feel like a victim. What else? There's a hand up over here. What emotions were off limits? Fear. You couldn't feel afraid. So the problem with this is we're human. We feel them all. No matter what, unless you have a serious cognitive or psychiatric problem, even then, we feel them all. We're animals, right? We feel every single one of these emotions. Fear, anger, sadness, disappointment, vengeance, jealousy, all the bad ones, all the good ones, we feel them all. So later on in life, when we were brought up, we can't be sad or we can't feel. So later on in life, when we feel sad or afraid, what do we really feel? We'll feel afraid and guilty, afraid, and ashamed of feeling afraid. So one of the biggest gifts you can give to someone when they're suffering is to let them know no feelings are off limits. Any feeling that they're having is okay with you. And this lets people feel what they're feeling and get through it. Praise that which has been lost, especially in the case of a death. Say yes to people's experience. This is just underscoring the same idea that we want to validate where people are at. not deny it. Sometimes we would think, oh, we've internalized these beliefs. Oh, I don't want to make their suffering worse, so I'm not going to talk about it. But what we find is actually being in there, getting down in the mud with people and feeling it with them is what comforts them. So this is another video from the School of Life, which is one of our favorite channels on YouTube, The School of Life, highly recommended, about how different people like to be comforted. Could you roll it, please?
Hey. How's it going? Hey, what's up?
I've had the worst day. I'm just so sick of everything going wrong all the time. And now it looks like I'm gonna lose my job.
Well, just talk to Janet. Talk to Janet. See if you can move into her department.
Just talk to Janet. What's Janet got to do with it? Why would I want to work in her department? I don't even like Janet.
This is good. This is really good because we've been talking about this for ages. You don't want to be there. And the only reason you wouldn't leave is because of the guilt. And now they've taken the guilt away. You're free. This is, if you think about it, this is the best thing that could have happened.
How on earth is staring down the barrel of unemployment suddenly the best thing that could have happened?
It's not good. It's not a good situation, but that's how life is and it sucks.
Great. Just accept this. This is what's happening. That is not what I need you to say.
What we can do is make you feel better, run you a nice bath, ordering some pizza, we sit and watch a film or something, just have a nice night.
Right, is that literally your solution to every single problem in the world? Have a bath and a pizza? I don't want to have a bath and a pizza. Just shove the pizza in your mouth and stop speaking for a second.
I'm gonna stop trying to solve everything and just listen to you.
So, I got up really early for the meeting and they cancelled both trains.
Oh, my train was delayed as well. It was a bit of a... Yeah.
I had to get on the bus. It was raining, I didn't have my umbrella. So I turn up 45 minutes late looking like a drowned rat to find Malcolm doing my presentation to the entire team. Didn't give me any credit for it. Thank you.
So we really like that one as well. It illustrates a couple of principles. One, we're different. Not everyone wants to be comforted in exactly the same way. Ultimately, it kind of recommends empathic listening, which is, what we're going to be teaching today and what we strongly recommend as well. But not everyone wants empathic listening. It's true. I think the situation I often think of is that how many of you have kids? You have maybe like teenage kids or college-age kids. They call and they're like, "Hi, Mom. Hey, Dad. How you doing?" And you talk and you think there's really some other agenda they have. What do they really want? They want money. They don't want empathic listening. And imagine if you just gave them empathic listening. Sometimes people want practical advice. And now with my daughter, who's 17, I ask her, I say, she come to me with a problem and I listen. I do all my empathic listening stuff, which she now can kind of recognize as my thing. But then I say, are you asking for advice? And sometimes she'll say, no, I just want you to listen. Another time I say, kind of grudgingly, yes, you can go ahead and give me advice. Now I don't give advice without consent. But the point is to try to, when you're wanting to help people, you have to find out what help they need and then give them that. And not assume we know everyone wants empathic listening, or we know everyone wants our advice, or we know everyone wants money, or whatever it is. Find out what they need and then give them that. So we all want empathy. Be curious. People won't listen unless they're heard. Emotions are the first item on the agenda. Health professionals are very interested in information. and not trained all the time to deal with all the emotion. So when you go into one of these disclosure situations or caring for one of your colleagues, emotions are the first thing on the agenda. Recognize them, validate them, deal with them, air them out before you deal with the other stuff. Let's face it, when it comes time to explain something and inform someone, you're not going to have any trouble with that. You've been doing that your whole lives. The explanation mode, the medical explanation mode, you're most comfortable with that. The biggest challenge for you will be to stay away from medical explanation mode when you're supposed to be trying to comfort someone. So be present first with the emotions. You'll get to the information eventually. And there's always more opportunities to give people things in writing, to explain things in more detail. If you don't deal with the emotions, you often can lose the whole interaction and relationship. Don't try to fix people's feelings. They're feeling the way they're feeling. Your job is to acknowledge and accept the way they're feeling, not to try to make them feel differently. You may come up here and struggle with what to say, or you might be thinking, I don't know what to say, I don't know what to say. Be curious. Ask people how they're feeling. Ask people how they're doing. Ask people what they know. So often in these difficult situations, questions open the door for you, open-ended questions. So what are you feeling? Tell me more. What's that like? What's been the hardest part? How are you doing? What do you know? All these questions are really, really good. And then once they talk, then your natural skills will take over. So if you're ever stuck, ask questions. And this doesn't don't feel bad if this doesn't come naturally to you. It's a skill. We weren't born knowing how to do it. It's a communication skill that, just like persuasion or public speaking or giving presentations or even doing explanations well or talking on rounds or something, you had to learn how to do it. So don't feel bad that you have to learn how to be empathic or to do reflective listening. And this, I think, is our... could you roll this one, please? Another videotape about empathy.
It's just, there's all this pressure, you know?
This is about not fixing it.
And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like... There's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just...
Don't...
Try to see things my way. Do I have to keep...
So we love that. How many people have seen that before? Yeah, it's been seen about 3 million times. It's getting harder and harder for us to find an audience who hasn't seen that before. But it does illustrate this point that we should focus on people's emotions and not trying to fix it. It also illustrates how difficult that can be sometimes when we clearly see someone else's problem. Right? Or we think we do, at least. And we also think we clearly see the solution. And we just want to tell them what the problem is, what the solution is. And they want us to be present for the feelings. And, you know, our experience is, if you listen to the feelings, there will be time to talk about the solutions. And people often ultimately want both empathy and practical advice in the long run. So the question is, what can we actually achieve with empathy? And what does an ideal empathic response look like? This is, you know, I'm a big fan of Abe Lincoln, as most people are. And I was reading his collected writings. And I'll tell you, some of those speeches are very, very long. They used to speak for a long time back in those days. But this is his most famous letter to this Mrs. Bixby, who lost all of her children in the Civil War. This is the letter that the movie of Saving Private Ryan was based on. They updated it to World War II, but it actually is a real letter that Lincoln wrote in the Civil War. And he says, you know, I've been shown the files of the War Department, a statement of the Adjutant General of Massachusetts. You're the mother of 5 sons who died gloriously on the field of battle. I feel how weak and fruitless must be any words of mine which should attempt to beguile you from the grief of a loss so overwhelming. Oh my God, what a beautiful sentence that is, right? If I could write one sentence that beautiful my entire life, I would be happy. But how weak and fruitless must be any words of mine. So he's talking about how language, we've reached the limits of language in trying to comfort people in a situation like this. But I cannot refrain from tendering to you the consolation that may be found in the thanks of the Republic they died to save. I pray that Heavenly Father may assuage the anguish of your bereavement, again, so beautiful, and leave you only the cherished memory of the loved and lost, and the solemn pride that must be yours to have laid so costly a sacrifice upon the altar of freedom. Yours very sincerely and respectfully, A. Lincoln. So this is what we're aspiring to, right? One can imagine that Mrs. Bixby was comforted by this letter when she received it, by the beauty and the eloquence of those comforting words. So with that, we're just a minute or two over, and it's time to head to the bathroom, get some more coffee, take a couple minutes. Tim, what time do we want to bring them back? Or do you want to say something first?
No,
okay.
Right around a little bit after 10:15. In the meantime, I've only got a couple more I've got to get up here. I'm going to put more communication assessments up there in alphabetical order that I've had a chance to take a look at. But yeah, I'd say 10, 15, 10, 17, and then we'll kick right in.
Awesome. Thanks for your attention. We'll see you in a few minutes.